Good morning, and thank you for coming, and thank you for having me. This is one of my favorite quotes because I feel that it captures the essence of the topic that I'm here to speak about today. And I'm excited to talk about the acute partial hospitalization programs at LVHN. Partial hospitalization programs serve as a bridge, and they close the gap between inpatient and outpatient care. They give people the support and structure so that they can return to their normal lives. My name is Zeeshan Javid. I'm a psychiatrist with LVHN. I'm also the medical director at one of the partial programs. Sorry. Today we'll explore what a partial program is, which patients can benefit from one, and how to identify and refer appropriate patients to these programs. So 3 simple but important objectives today. LVHN has 3 partial programs. 2 are for adults and 1 is for adolescents. They are strategically located across Lehigh Valley to cover both the eastern and western ends. Adult Transitions is located in Allentown across from Cedar Crest Hospital. Alternatives is located at Muhlenberg Hospital in Bethlehem. And the Adolescent Partial Program is in the same professional buildings as Adult Transitions, also across the street from Cedar Crest Hospital. So now you know where these programs are located. Let's take a closer look at what a partial hospitalization program is and what makes it unique. These programs are short-term, intensive outpatient programs designed to give mental health treatment to persons who do not need 24-level observation. Key features include 6-hour-a-day programs, 5 days a week, so almost parallel to what a school day would look like. Individual therapy as needed, group therapy, family therapy, medication management, and psychoeducation. These programs are led by a multidisciplinary team, which typically includes a psychiatrist, nurses, a dietitian, and therapist. There's a focus on stabilizing acute symptoms, hopefully to prevent hospitalization, and also to improve functioning. In my opinion, the best part is that patients can return home each evening where they get to spend time with the people that they're connected to, and also they get to sleep in their own bed. So they get to be in their home environment. Now that we've defined a partial hospital program and what it is, let's take a closer look over some general information. The adult programs are for persons over the age of 18 and that are no longer in high school. The adolescent program takes care of adolescents from the ages of 12 to 19, as long as they're still in school. Outpatient treatment is paused while the person is in the program, meaning that they wouldn't be having appointments with their therapist or a psychiatrist. And the adult programs do assist with access and transportation in providing bus passes. Some insurances like Medicare and Medicaid can support Lantavan or also pay for ride-sharing services like Uber and Lyft. To ensure that we're at the utmost quality, the programs are licensed by the state and the Joint Commission. The adolescent program will provide 2 hours of schooling each day, and I'll talk more about that a little bit later. Again, the programs are daily Monday through Friday with the weekends off, and most insurances are accepted, and the program will also do a utilization review to ensure that there is coverage throughout one stay. So we've covered how the programs operate. Let's talk about when a PHP is the right level of care. First, it could be when a person is in need of a higher level of support, and it could be that they are stepping down from a hospital where the crisis situation may have been stabilized, but the inpatient admission serves as a stepping stone as to further work that can be done in the outpatient setting. It can also be serving as a diversion from someone who is engaged in outpatient treatment, but needs more support than what a traditional outpatient treatment can provide. And so it can divert someone from having to go to inpatient treatment. It can also be used in what I would call a contained crisis. And so individuals that may not be connected with mental health services and they're working with their PCP or they're presenting to the ED with a behavioral health complaint, whether it's to tackle a mood or anxiety disorder, they've noted that there's some impairment and they're struggling in their daily life. So now we've talked about when a PHP is appropriate. Let's take a closer look at the admission criteria and what it means to meet medical necessity. The patient needs to have crisis stabilization and treatment. So in other words, the symptoms are severe and they require daily monitoring. And there has to be a presence of psychiatric symptoms that are causing impairment on a day-to-day basis. And it could be in their personal lives, social lives, work environment, or educational functioning. Essentially, their functioning or their safety has been disrupted. Lastly, there has to be sufficient gains that have not been met in the outpatient setting. And so when the outpatient treatment is failing, a higher level of care is necessary. But at the same time, 24-hour supervision is not needed. In addition to medical necessity, patients must possess certain factors to participate in the program. They must be physically and intellectually having the capacity to actively participate in a group environment. That means that a person would have the ability to reflect, give feedback, and to accept feedback from peers. They would have to exhibit behavioral control and show that they're not dangerous to themselves or to others. Obviously, that's necessary for the safety of the program and also the peers that are in the program. They should also have social supports that are available to them so that they can be maintained in the least restrictive environment. A person without social supports may do better in an inpatient setting. They would also need to have the motivation and willingness to actively participate in group therapy. Someone that wouldn't be motivated to work on themselves or to help others work on themselves wouldn't be the best fit for this type of program. And if the patient is currently in the inpatient setting, then they would need to be ready for discharge and also ready to engage in more intensive treatment. So just as we know that there is a specific criteria for admission and being appropriate for PHP, we can also imagine that there's times when the level of care is not appropriate. Patients that have a history of violence or threatening behavior may be at risk for repeating that behavior. It's important to keep the patient safe and also have the staff available to respond to that. It's also important to keep other peers that are participating in the program safe as well. If a patient is refusing to abide by the rules of the program, it generally doesn't work well. If someone can't maintain that they're going to attend at a certain time, that obviously would destroy the group milieu. If there's sound evidence that a person has tried the modality before and has not been successful in terms of adhering to the program, if they previously tried but had multiple absences and the situation at home or in their personal lives has not changed, then they're unlikely to benefit again from the program. If there's a history of sexual abuse, that can be, if there's a history of the perpetrator of sexual abuse, That is something that typically does not do well in the group setting as well, because it can trigger other peers, and there's a concern of boundaries being violated. There should be adequate support at home, such that if a person is at high risk, we will want to make sure that after hours the person can be maintained at their home or in the community. If a person experiences agitation, if they're experiencing a manic episode or a psychotic episode or significant substance withdrawal, then they wouldn't be appropriate for the program, because they wouldn't be able to engage in the therapy that's being offered. So until those symptoms are resolved, the person couldn't be considered. Overall, they have to have the ability to tolerate group treatment. That means sitting in a group for several minutes at a time or several hours throughout the day. If there's any current active alcohol use or substance use, that can be complicated. And typically when we see that happen, meaning that if a person hasn't disclosed it initially, we can see that they typically don't progress towards their mental health needs until we can have an intervention for the substance use. I did put an asterisk into the title of the slide, indicating that our team is always available to discuss cases, and sometimes that conversation can be quite fruitful, because the initial person who's making the referral might come up with other ideas or suggestions for modalities that could be helpful. So now we covered who may not be appropriate for the program. Let's shift to the conditions that we treat. The concerns that we address can be fairly variable. Not uncommon for people to come into the program if they have an anxiety disorder. It could be PTSD, it could be a recent traumatic event that they're having difficulty coping with. Could be a loss. Mood disorders are common as well. Depressive episodes or hypomanic episodes, with or without a trigger. And emotional regulation or poor coping skills, where a person has lost functioning because of their symptoms. A person with suicidal thoughts or self-harm behaviors, but without being at imminent risk. Again, if someone was at imminent risk, then inpatient treatment would likely be recommended. Many people will come to us when they've had changes in their relationship. Could be marital conflict, it could be a situation where their partner and them are having more arguments, or someone has made a challenging decision for the household. If there's a functional decline at work or at school or at home, new legal involvement. If there's a person who's never been involved with the legal system, it can be a quite stressful experience to have to deal with the law, understanding what the legal process includes, and this is typically even before they've talked to a lawyer. And finally, medication management is also a component as to why people might come into the program, knowing that there could be closer monitoring while they get therapy and also medication management. The overarching goal is to provide a safe place for patients where they can develop skills, face life's challenges, manage their illness, and ultimately restore their prior level of functioning. So let's look more closely at what our programs provide. And it's essentially 4 separate categories. The first one is skill development. Patients will benefit from a processing group as well as a psychoeducational group. I will talk more about these 4 in the upcoming sections. Medication management, which I just mentioned, we want to try to optimize a person's medication regimen and also monitor for side effects if there are any. Family support and involvement, and discharge planning as they step down from the partial program and transition back into the community. So skill development and the processing group is what I consider the heart of the PHP experience. A supportive space is created, and groups are typically no larger than 10 people, and they're led by a therapist, licensed and experienced to operate a group. Evidence-based principles include cognitive behavioral therapy, where a person may benefit from examining automatic thoughts, cognitive distortions, recovery principles of care that can emphasize peer connections and mutual support. Patients will typically say to me that when they're in the program, they feel that they're not alone. And it's reassuring to know that there's other people that have experienced similar things or are going through similar experiences. Because there can be a range in ages, it's not uncommon for someone to have gone through a life situation when they were younger, and they can pass that wisdom on to some others. And so they really do appreciate that as part of their recovery journey. Dialectical behavioral therapy and skills are important to help patients stay grounded and also stay in the present. Positive psychology really helps people understand purpose and meaning in their lives, certainly reconnects them with their values and gives them hope for the future. So these skills are not just used during the crisis or during the program, but they are meant to be used long after a person has been discharged from the program. And so the second component of the skill development is the psychoeducational groups that complement the processing groups. And whereas the processing groups will focus on insight and emotional exploration, the psychoeducational groups give practical tools and knowledge to be used on a day-to-day basis. Communication skills can help patients learn to express themselves clearly, can also help them decrease conflicts and improve their relationships. Obviously, coping skills can help them in different aspects. Diagnosis and medical education are fundamentally important. Many persons will not know what their diagnosis is. They might have an epiphany when symptoms are better clarified. Oftentimes, patients will tell me that they weren't aware that bipolar disorder, for example, is a misnomer, and you don't need to have both poles of mania and depression, but just one manic episode. There's also an emphasis on medication education as well. Distress tolerance, emotional regulation, mindfulness can help with intense emotions and keep patients grounded. Relapse prevention can help patients identify early warning signs or triggers so that they can avoid having setbacks. Safety planning and suicide prevention can enhance emotional and physical safety. Self-esteem, self-hygiene, stress management. These are things that nearly all of us can use as a refresher from time to time because they promote wellness. Support systems and community resources. Oftentimes, I'll meet with patients that are depressed. One of their symptoms is that they feel that they're a burden onto other people, but when you speak with their families, they essentially learn that that's far from the truth, and their perception of being a burden is very different. And lastly, wellness, recovery, and action planning, which is a structured approach to empower patients to take an active role in maintaining their recovery and planning for the challenges ahead. These groups give people skills, confidence, and self-awareness to be successful in their daily lives. Alongside the therapy and group skills, medication management ensures that we have individual treatment plans and that patients are closely monitored. Within starting a PHP, there's an assessment done by a psychiatrist, a nurse practitioner, or a physician assistant. The assessment helps to guide treatment. Not all patients will need to take medications. Some patients will choose not to take medication, but it's always valuable to have that discussion and also to know what options might exist in the future. If medications are initiated, I do remind patients it's one of the safest places to start a medicine because there's going to be observation 5 days a week, and so if there are side effects, they can immediately support it. And even on the overnights and on the weekends, there is coverage on call so that they can always speak with someone. The adult PHPs have patients self-administer their own medications as prescribed. This encourages independence and accountability for patients that might be struggling. It's not uncommon for them to meet with the nurse just to review instructions or to organize medications. Aside from the psychiatric medications, they may have a number of comorbidities that also require medications, as illnesses like diabetes and hypertension can be quite common. For the adolescent program, we will have the parents deliver medications to a nurse in a labeled vial for storage, and then the nurse will assist the patient in self-administering their medication. This ensures safety and also learning for the child. So beyond individual and a group therapy, an essential part of the partial program is to involve people that are supportive to our patients outside of the program. And this is where family sessions come in. Discussions typically center on how to improve communication amongst the family members, how to improve acceptance of a mental health condition. Not uncommon for someone who is new to the mental health continuum that they may have family members that are just not aware as to what mental illness can be and how it can impact a person's life. There can also be some benefit in changing the family dynamics in a constructive and meaningful way such that a patient feels that they're supportive. This is an integral part of the adolescent program, naturally due to the parental involvement. And so there could be multiple meetings. But overall, these sessions can create an opportunity for greater understanding, empathy, and collaboration. A key part of making the PHPs effective is how we prepare for success after discharge from the program. And so this brings us to our next component, which is discharge planning. It essentially involves considerable case management. But when this process starts is typically from the first day, as we're foreseeing what the future is going to look like to make sure that a person is connected with a therapist, or if there's going to be medication management, if they're connected with a psychiatrist or with their PCP. Case management services can be helpful, especially ancillary programs are being recommended, like Clubhouse, for example. Some of our patients may have support groups that they can benefit from in the community, and they may not otherwise know what resources are available to them. The goal is really to create a seamless transition to promote stability, recovery, and continued growth. So after discussing how we support patients through the discharge process and beyond, let's shift our focus to how patients come to our programs. And with the referral process, we will typically take referrals from psychiatrists within our health network, psychiatrists within the community, psychiatrists from outside the health network that know that we're available to them. The same thing goes for therapists. Emergency departments will often see someone with a crisis episode or presenting with mental health symptoms for the first time, and will turn to partial hospital programs because the ease of access, where they recognize that a person might have to wait 6 months for that psychiatry appointment, but it could be just 3 days before they're admitted to a PHP. Primary care office are also a source of our referrals. PCPs will recognize that there are limitations in their time and also their expertise, and they'll often turn to partial programs to help their patients feel better faster. The adolescent program will take referrals from schools. Not uncommon to see that guidance counselors will make the referral. School can be a very stressful time for children. I always remind parents recognizing that a workplace or work environment can be quite stressful for a person, but they always have the option to just change jobs. And for schools, you don't necessarily have that option. So once a referral is placed and it's been received, the next step is to determine whether the PHP is a good fit. And this begins with a comprehensive screening process. As part of the referral, we conduct a detailed screening to ensure each person meets the clinical and safety criteria. Obviously, we'll look to see what the reason is that the person is being referred, if there's a diagnosis or what symptoms are present, and also reflecting back to what the admission criteria was and what precludes a person. We will take a brief inventory in terms of their history, which includes suicide attempts, self-interest behaviors, history of aggression. There are some conditions that we know that we can't effectively treat, and if there's the presence of an eating disorder, we're not going to recommend a modality that's going to fall short of the patient's needs. And the same is true with alcohol and substance use as well, recognizing that a dual program might be better serving, or once the substance abuse is addressed, then we can focus on the mental health needs. If there's any specific issues regarding legal matters which might affect attendance, and also if there's any concerns about safety or their medical health, simple things such as having low back pain, for example, might make it very difficult or even intolerable for a person to sit inside a group for 45 minutes. And we also look to see if someone's connected with current mental health providers as well, recognizing that there's going to be collaboration in terms of their treatment and care. So ultimately, we're looking to make sure that we can safely and effectively have patients participate in the program. Once a patient has been determined to be appropriate for the program, safety remains as our highest priority throughout their treatment. And the typical length for the program could be, on average, from 2 to 4 weeks. So upon admission, every patient will develop a safety plan, which identifies a connection between the circumstances, the triggers, the symptoms that a patient is having, and how it relates to suicidal thoughts and behavior. It also helps to identify what supports are available to that person in the community, meaning that their personal supports as well as crisis supports. Upon admission and discharge, we do a Columbia suicide severity rating scale assessment, again, organizing what the risk factors would be. And on a daily basis, we will have patients complete a daily journal, which includes questions about safety. And before the day ends, we do a wrap-up with each patient where a safety check is completed prior to a dismissal, and we have the patients first identify that they're safe, that they know who to contact if symptoms worsen, and if they're aware of the resources that are available to them in case if it's an emergency. In addition to daily safety assessments, we have additional safety protocols. Upon admission, we determine if the person has access to lethal means, which could include firearms, it could include weapons, could be a stockpile of medications that they've had previously. With their permission, we make an effort to reach out to family to make sure that these methods could be safeguarded, and so we'll ask a family member to lock away the firearm or give it to someone else for holding. Same thing is true with medication, or if there's sharp objects or things that could be used as a weapon in the house. And Again, the safety plan that is created upon intake is reviewed before discharge, and it's updated to make changes accordingly. We also make sure that patients are corresponding with the program on a daily basis. And so the expectation is that they're going to have perfect attendance. If for some reason a person is feeling ill or if they overslept, they're not going to make it to the program on time or not at all, we would expect them to call the office so that we could do a safety check with them on the phone, make sure that they're not having suicidal thoughts. If we can't reach the person, then we will reach out to their emergency contact, hoping for some collateral information, and potentially they would have a means to get in touch with the program. And if that person cannot be contacted or reached, then we would also consider contacting the county crisis intervention unit to do a welfare check on the patient. Multiple layers of communication, but we certainly need it for accountability and to make sure that every patient is monitored for safety. And so I would like to talk more about the adolescent program, just to point out that there is a certified special education teacher who will work with the participants of the program for up to 2 hours a day. This will give the patients exposure to school, which can be highly stressful for many students. It also prevents them from falling behind in their coursework, such that they're not left with the burden of making up work after their discharge or feel that they have to catch up over their winter or summer breaks. Also to develop a reentry plan, recognizing that the patients will be under less stress, recognizing that there's a plan in place. Sometimes the program can also make specific recommendations when it comes to accommodations. They can also confirm or diagnose ADHD, learning disorders, or conditions that may impede one's learning. And so it can generally be a fairly valuable asset to the student. So even with the structure, support, and healing that we can find with our programs, we still find that they're fairly underutilized. And so it's worth exploring why that may be. First, I feel that there is limited awareness. Many times, maybe even once a week, I'll hear from patients telling me that they had no idea that something like this existed. PCPs in the community may not know that this is something that's available to nearly everyone, and the referral process is fairly straightforward. Missed work or school is a logistical reality for many people. Some patients cannot afford to miss a paycheck, and they don't have the luxury of taking time off. Some parents will be keen on advocating that a person or their child continue with school and postpone mental health treatment for out of school or during the summer. Transportation can be a challenge. Previously I mentioned that bus passes could be available, and some insurances will help with ride-sharing services. But from a logistical standpoint, if there's one vehicle for the household and there's multiple people that need to use it, it can be quite problematic. Childcare responsibilities are not uncommon. So patients with young children who cannot get a family member to assist with childcare may find themselves in a disadvantaged position. And also, we can't ever forget that there's an ongoing stigma when it comes to mental health, and so there can be resistance, not just from the patients we treat, but also the families. This is the same sort of resistance we see from inpatient treatment as well. But part of our mission is really to increase awareness and understanding of the partial programs so that the community can see them as a vital bridge between inpatient and outpatient treatment, between crisis and stability, and ultimately between illness and recovery. So in summary, our PHPs do offer an important space within the continuum of mental health care, and I'm proud of the work that we do. I hope that this presentation helps to build some awareness. And before I open for questions, I would like to share a video that highlights our PHPs and also gives you a feel for the environment. So I hope we can play this because if you look closely, you'll see some good-looking people here.
Lehigh Valley Health Network offers 3 acute mental health partial hospitalization programs, referred to as PHPs. We have a program for individuals ages 12 to 18 and enrolled in school, and 2 programs for individuals 18 or older. PHPs are an option when mental health symptoms remain severe and prior interventions have not provided relief in managing symptoms. Our programs are a good choice if you need more than outpatient therapy and medication management, but don't need inpatient hospitalization. If stepping down from inpatient care will help you gradually adjust back to daily life while still receiving structured support and intensive therapy as part of your recovery. The goal is to provide a safe environment where you can develop the skills needed to face life's challenges, manage your illness, and improve your overall sense of well-being. Participation in our PHPs is always voluntary. The average length of stay is 12 treatment days, but everyone's timetable is dependent on a variety of factors. Our multidisciplinary team of clinicians, therapists, and RNs are experienced with a full range of mental health conditions. We address anxiety, depression, or other symptoms that interfere with daily functioning, as well as help with stressors including employment issues, marital distress, parenting challenges, interpersonal conflict, and grief or loss. Our adult partial programs consist of group therapy Monday through Friday from 8:30 to 3 p.m. While many individuals are nervous about participating in group therapy, most patients warm up to it when they can see the benefits of connecting with others. You'll also have individual weekly check-ins with a clinician to review your medications or to explore if medications may be helpful in managing your symptoms. In our adolescent program, you'll collaborate with clinicians, therapists, case managers, special education teachers, and nurses. We help you and your whole family understand, navigate, and cope with the challenges you're facing. For adolescents, the treatment day is Monday through Friday from 9 a.m. to 3 p.m. The program is both clinical and educational, so you can still meet state requirements for out-of-school instruction while receiving the treatment you need. At Lehigh Valley Health Network, we support you during your course of care and prepare you for ongoing outpatient treatment following discharge from our PHPs. With our help, clients can develop strategies to manage life stressors and improve their overall sense of well-being. You can too.
And so before I take questions or comments, I will point out that directly outside this theater, there's a booth with LVHN that will have brochures and further information if you'd like. Any questions? Right there. Right there, please. Oh.
Yeah, I was wondering if ICMs or CPSs can refer, because I saw your list and they weren't on there. And a lot situations, they're the person that's involved the most.
Absolutely. So I think that having a case manager who is aware of what the patient's needs are would certainly be an appropriate referral. This is probably a person that has connections with other mental health needs, and so obviously, like we would want the treatment team to be in agreement. So if they're working with an outpatient therapist and a psychiatrist as well, we would like to see that they are all in agreement that this is best for the patient. But it's almost an open door. So because we take self-referrals, you can imagine that any call that's coming, we're going to carefully consider and see how to best help that person. And I know the staff very well, and they're always looking to be helpful. They're not looking to turn someone away unless if they have to, or if they feel that a different modality is needed. And so commonly what might happen is if a person's apprehensive about doing inpatient treatment, but really we're concerned about their safety, we might recommend that they do inpatient before coming to the program. But to answer your question, absolutely, a case manager can make that referral.
One other quick question. I've had several people have difficulty getting into either hospital's program. Is there any growth in these programs anticipated so there's more open slots?
If the issue is attendance or that there's not any slots available, that is certainly something that can be scheduled around when we have discharges. I've not heard recently that that's been a major issue. So I'm not sure if your problems have been with the adolescent program. Sometimes things are seasonal. So when school is out, the adolescent attendance typically drops. When school starts, it picks up. But if we're ever at capacity and we know that there's someone who needs help, we would have them scheduled to start when we're anticipating a discharge.
Thank you.
Do you admit people who are currently living in a shelter?
Homelessness can be problematic because that is a basic need that could impact how a person participates. We would have to look at it on an individual basis. Obviously, ensuring that there's transportation to the program would probably be my bigger question. So if they're living in a shelter and that environment has been comforting and stable, that would not preclude someone from attending the program. It would be more so the other factors that I had listed in that previous slide, with transportation being my biggest concern. Can they make it to the program when it starts at 8:30 every morning? Would they have a way back? Are there supports within that shelter that they have access to? Or if it's not within the shelter, are there other community supports that are available to that person? So I think if anything, that would just be a conversation, but it would not preclude someone.
In reference to the transportation, years ago, there used to be van transportation. I'm not sure why it ended, but is there any chance of bringing that back?
So you are correct. About 3 years ago, there was a van service that serviced both adult partial programs, and that program has been discontinued. Currently, there's no plan to bring that back.
This is just an option for transportation if you're in need. If the individual is open up to Northampton County Mental Health and has a $0 liability, we can give up to 15 all-day passes every 30 days. So that could be a help to somebody.
It's good to know. Thank you. I can say that these seats are very comfortable, and perhaps we should bring them into our partial program. I was ready to take out my popcorn. Any other questions? I thank you for your time today.